Okay. Thank you, Vicki. Whoops. Thanks, Vicki. My name is Pam Baston. I know I've been here before and may have met many of you, and it's a pleasure to be back. A little bit about my background, so when we get to some discussion points that might help a little bit. I've been in the substance abuse prevention and treatment field for 31 years. Started out working with sex workers in a methadone treatment center in Tampa, Florida, and also worked in every modality of substance abuse treatment for about 7 or 8 years. Then had an opportunity to head up Florida's publicly funded drug treatment system, prevention and treatment actually, in Florida. Did that under a couple different governors. And then had the career highlight, I think, of my an opportunity, which was to run the family treatment program for primarily women and whatever size family they had, along with their partners, which may have been male partners, female partners, married partners, unmarried partners, grandmothers, pets, whatever was the family constellation we served. And we had a 100-person campus in Key West. And that was a lot of, learned a lot about treatment by doing that, and I'll share a little bit about that later. And then most recently, in 2007, I started working for the National Center on Substance Abuse and Child Welfare. I just do that part-time and do other things. But in that role, I have worked with a few states in helping their child welfare, substance abuse treatment, and court system work more collaboratively and effectively around families that are dually affected by child maltreatment challenges and substance abuse. So a couple of the states that I'm in is Connecticut, New Jersey, Nebraska, and then also we work in Miami. So that's a little bit about my background, and what I'd like to do is to get a show of hands on, just so I have a sense of who you are. I'm going to ask the question of how many of you are with addiction or mental health treatment, how many of you are with child welfare systems and then or agencies, and then also the courts, and then maybe all others. So if I could just get a sense of how many represent, let's say, behavioral health in some way. Okay, good, all right. And then what about child welfare? Okay, and the courts? All right, good. And all others? Anyone else? Okay, and who would the others be as an example? CASA, okay.
Or foster parents.
Foster, yay, oh, that's wonderful. Okay, who else? Magellan, okay, great. All right, anyone else that I didn't ask that's others? Okay, and then I am, as people who have worked with me before know, I'm very frank. And so I just kind of say things, you know, as in terms of, you know, where we have years of experience where things may be not as effective as they could be. And when I say things like this, just want you to know I'm not speaking of specifically a Nebraska situation. So when I just as some context, I'll make comments about, you know, in other areas, or typically these are the things we see. So please know if I have some specific information about Nebraska, I would obviously share that. And we will be sharing some data around some findings in Nebraska a little bit later. So just a quick background about the Nebraska effort. Nebraska put forth an application a couple of years ago to get technical assistance from the federal government on how to improve services to substance abuse and child welfare families. And this is an initiative funded jointly by SAMHSA, the Substance Abuse and Mental Health Services Administration, and the Administration on Children and Families, and it's really the Children's Bureau of that. And so really the nice thing is that this effort is jointly funded by 2 federal agencies who tell y'all to collaborate, and now they're collaborating and putting their money where their mouth is by funding this project. And you don't get money, but you get technical assistance and other types of resources. The parent company of this effort is Children and Family Futures. There are 3 different initiatives. All 3 of them you have in your state, interestingly enough. Today we're really only looking at that which is involved with the National Center on Substance Abuse and Child Welfare, but we also have an RPG project, a regional partnership grant. I believe it's an Indian tribe that's on the border of Nebraska and I think Iowa. And then you also have an OJJDP. We run the technical assistance for OJJDP FDADP, family dependency drug courts, and so you've got an initiative here. So you've got a lot of efforts going on in your state that work with our company. And I don't really want to go into much here other than to say this is the organizational structure that governs the technical assistance effort that's happening here in Nebraska. I think I saw Janice Walker here. She's a member of the Oversight Committee. I don't believe we have any other Oversight Committee members here. And Janice, I just want to let you know how much we appreciate your leadership and for you taking the time to be here for whatever time you can share with us this morning. And Vicki Weiss is on the core team, and I don't believe we have any other core team members. But hopefully at some point we'll ask y'all to be involved in some of these work groups, the 4 work groups that we're looking at making improvements in Nebraska. One is screening and assessment, one is best practices, another is data and information sharing, and another is training and workforce development. Just so that's enough of sort of the background of context. We have an advisory committee, and then that's me to the right. So what we want to do today is talk a little bit about, first, just a background on addiction. Much of this will be a refresher to you, but it's an important conversation to have to provide the context for the discussions we're going to have today. And basically, this speaks to, and you've got these handouts, that up until about the 30s, addiction was really looked at as a moral failing. There was no understanding of genetics, of environment, of the brain science. None of that was there to inform our thinking. And so we believe that people were morally flawed, and we really just said, you know, it's a choice they're making, and they made a bad choice, and so these are problems that ensue with addiction. But I want to read this definition. Again, you have it in your packet, because there's a couple of key concepts that are here that really are a foundation for what we'll be talking about today. So a core concept that has been evolving with scientific advances over the past decade is that drug addiction is a brain disease that develops over time, that's key, as a result of initially voluntary behavior of using drugs. The consequence is virtually uncontrollable compulsive drug craving, seeking, and use that interferes with, if not destroys, an individual's functioning in the family and in society. This medical condition, it demands formal treatment, and formal treatment is another word that I want to emphasize here. So there's some themes here. Yes, addiction begins with some voluntary behavior. Obviously, you can't be addicted if you never pick up in the first place. But that then something else takes over time, which also means the earlier you identify someone, the better that person's chances are of not succumbing to a more intractable condition. And also that drug use interferes and destroys with functioning in the family and other kinds of things. So there's reasons to intervene, and that it's a medical condition that demands drug treatment, not just drug testing. We're going to come back to that in a few minutes. So addiction affects multiple brain circuits, including those that are involved in reward and motivation, learning and memory, and inhibitory control over behavior. So here we also introduce the concept of genetics and also the environment. So basically that if somebody is born to a parent that has alcoholism or drug addiction, they may have be genetically predisposed to develop addiction themselves. And what that would mean is if there were, if you and I were together, going into a situation and I had genetic predisposition to use and you didn't, and we each drank alcohol, my physiological reaction in my body is going to be very different than yours. I'm going to have the inability to stop at some point. I'm going to be more rewarded. My brain circuitry, everything is going to be different when I use than you. Same amount of alcohol, very different responses. And so that's part of, and then if you add environment in there, that adds a whole other level of complication. Does it mean that every person that is genetically predisposed will go on to develop addiction? No. There are other protective factors that can happen. This is a very important slide, and I'd encourage you, if you haven't been to NIDA, the National Institute on Drug Abuse website lately, to look at the brain science. We have done amazing things with PET scans over the years, the field has, and we now are able to look at the impact of addiction on the brain and to be able to prove that there is a complete impact on the brain by drug use over time that causes conditions that are well beyond just willful behavior. So here's an example of a healthy person's brain. Then in the middle is 1 month of abstinence of a person using methamphetamine. and then 14 months of abstinence, and that's the time frame for lengthy meth use of how long it takes the brain to return to a relatively normal state of functionality. And I don't pretend to be a doctor, but I have stayed at a Holiday Inn Express, and I do know that basically some things here about this is that it's not a situation of somebody being able to stop using drugs, especially after many years of drug use, and they're not able to understand everything you're telling them to do, especially complex directions like we're prone to do in child welfare. We take someone's kids away and then we give them 17 things we expect them to do, most of which is not even written down, even if they have a good literacy, and we send them to all kinds of complicated bureaucratic processes that many of us could really be hard pressed to explain. And then, and many of these appointments contradict and coincide with each other or on opposite ends of town, and we don't collaborate to always know where we're sending people at the same time. And then they often have lots of barriers, which we'll talk about in a minute. And then, when they don't show up, we say, look at that. They weren't motivated. They're just resistant. They really don't want their kids back, or that's all you can expect from someone who has a substance use disorder. And so our failure sometimes as a system to understand how complicated this is in terms of the brain science does a tremendous injustice to the clients that have this disorder. And also, when you talk about reasonable efforts, and I'm going to bring that back a lot because my contention, and it's almost in every state in this country, is that we are not meeting the reasonable effort standards and expectations based on what we offer clients. Yes, and I'm glad we're asking questions. Yes?
That slide shows a pattern with a meth user. Would it be similar for other drugs or alcohol?
Yes, we do. I don't know about alcohol, but I know other drugs, and that's a very good question and something that I should know, and I will make a point to find that out. But the ones on NIDA only look at drugs because it's National Institute on Drug Abuse, but and I'll go to the National Institute on Alcohol and Alcoholism. But basically, yes, the brain is affected by all other kinds of drugs, and one of the factors is the length of time that they use and the amount of drugs they use to look at what type of damage is there. But the areas that are affected are memory, are impulse control, cravings. Cravings are huge, and you can literally, and I've had the benefit of seeing this, have people that have addiction issues that are trying to seek recovery that will be shown nothing more than pictures of drugs or pictures of people, places, and things that they used to associate with when they had drug using behavior, and their brain lights up. It is just, it's an amazing thing where someone else that does not have an addiction can see that and have no reaction, no cravings, no nothing. And it can happen even years beyond their initial attempts at recovery. So there's a lot we don't know, but we do know that this is a very complex, and it should be treated as a complex, recurring, relapsing condition. And we'll talk about that in a little more, and thank you for your question. And I know we're a larger group. I've been talking to 15 and 20 people in rural parts of Nebraska, but please feel free to speak up if you have any questions or comments. So one of the things that is a little challenging is, despite all these advances in the field of addiction, there's still a lot of misconceptions and myths that abound. And I'm very sad to report, as somebody who spent 31 years in the substance abuse field, in the last 15 or so in co-occurring mental health disorders, that sometimes the very people that should understand this the most, those being in the addiction and behavioral health field, are some of the same ones that have the misconceptions. And so those of you that don't represent that field, that are in the courts and that are in child welfare or foster parents, how can we as professionals in addiction expect you to get it if sometimes we don't get it? Or if we promote the same mythology and the same incorrect information or our same biases that are not informed by the research that is widely available, it's really not fair to expect you to get with the same understanding. So this is the big challenge that we have, frankly, in the field. And this plays out in a number of very sad ways. I'm going to give you the most serious example. And that is in the case of opiate addiction. Now, I do spend a lot of time in the Northeast, and I know that's a bigger problem than it is here. And by opiate addiction, I don't mean just, for example, heroin, but even some of the prescription drug use pills. And we've got a tsunami of prescription drug use problems happening all over this country, and if it's not here, it will be, and I'm sure it already is to some extent. And so most of the prescription drug use issue is around opiate prescriptions. And so one of the most effective, long-standing, proven programs that has more than 40 years of research, in fact, the most widely studied addiction treatment, is methadone treatment. And I say methadone treatment, some people say methadone maintenance, and the point of it is that methadone, which is typically given in like a orange juice or Kool-Aid type mixture that you drink, the methadone is put in by a nurse in a program, and you drink it every day a little bit, or you take a wafer. There's different types of methods. But the point is that it does not make you high at all. All it does is stop all that crazy brain circuitry, all the cravings and all of that that happens that would normally cause you to go back out and use to stop. Just as somebody who has bipolar disorder, who might take lithium or some other medication to be able to maintain a healthy balance in a normal life would do. And so what happens is you've got these myths that say, oh, well, if you use methadone, you're just changing one drug for another. Absolutely not true. You know, that methadone does not give you that high effect. All it does is stabilize your functioning. And I'm trying to get a copy to y'all of the latest study that literally I was reviewing the DVD before I came here, that was that folks, and so we do things, we practice medicine without a license often. And they do this in New Jersey, I'm sad to say. Their child welfare system was literally telling pregnant women who were on methadone, you need to hurry and get off that methadone because you are killing your baby. And the reality is, if you get off methadone when you're pregnant, that is what will happen. You could have fetal distress and death. It can affect the mom. Absolutely not what you want. I'm surprised they haven't been sued. And so basically, not only do you want a woman who is on methadone, who is pregnant, to stay on methadone all the way through her pregnancy and beyond in particular. What is this, anyone that had a baby knows how stressful it is to have a newborn, and especially if you don't have all the support and guidance and resources that many of us in this room are blessed to have. So you want them to stay on that. So we do harm, and I will, like I said, I say it like it is, we do harm every state in this country and probably every town in this country. I will say probably unintentionally. I don't think people set out with malintent, but we do harm, and we have some responsibility if we're choosing this field to work in, to be knowledgeable about the diseases and the disorders and the issues that we have to deal with, and to not, if we don't know, don't promote misconceptions and misunderstandings, and don't take those same myths and put them out there if they're not correct. Yes?
Mm-hmm. Is it a lifelong?
Good question. So her question is it a lifelong process if you're put on methadone to deal with your addiction? So say I have bipolar disorder. I had a former husband who had bipolar disorder who passed away, and I lived that for 7 years, and it was a roller coaster. And he learned every time he would start to do well, and I know that those of you who've dealt with this disorder know, he would say, I don't need this anymore. I'm fine. I'm better. And he would go off. And so what would happen? You know the answer. So we went through 7 years of absolute chaos, burned our family home down when he wasn't on his lithium, and other kinds of things. Our life was total hell, when he was not on his medication. His mother took her life when she was not on medication. So the consequences are very severe when you do not take the medication that your doctor and your team prescribes. So the same thing happens with methadone. You would never say to somebody, oh, I'm so glad we straightened out your diabetes and your hypertension and everything's good in your life, and now we're going to take all that away, all those meds that have helped you, and especially now that we understand the brain science, that we're going to just yank that from you and we expect you to move on. And usually for a short time they can do okay, but not for long. So for many people, and you reminded me that I forgot to give you the statistic I was going to tell you about, that for many people the period that they need to be on methadone is several years. Some are lifelong, but it's something that is in fact, the research that I was looking at before I left to come here was that something like 5% of the people who try to get off methadone in less than a year are in recovery 5 years later. And 50% of those who stay on methadone are in recovery. And that statistic, by the way, 50% is about the same as the rest of our field if we do treatment, effectively. So really, methadone treatment is just as effective as other treatments if you stay on that till the period of time that's needed. Which, I mean, we have 70 and 80-year-old people in methadone treatment that are having very successful lives. Yes.
I've had cases where it looks like the stuff being passed around recreationally. So I'm confused.
Okay, good point. So you're talking about diversion. And this leads to two important distinctions. One, when I talk about methadone, I'm talking about your methadone treatment centers and clients who are receiving methadone treatment. There is a distinction in that because methadone is a synthetic opiate and can be used for pain management, that there are some private docs who do prescribe methadone in a number of, I believe in pill form primarily, and that is the easiest to divert to the street like any prescription would be. And I also need to say that there are some methadone programs, just like there are some other treatment programs or any kind of business you would have in America, that are less appropriate or less of quality than others. So we do have, not many, but in this country there are some poorly run, poorly managed methadone programs where there may be some diversion. It's very hard to divert the liquid. You're going to hold it in your mouth and spit it out in the parking lot. I mean, I guess you could. Okay, but the diversion primarily comes from the private docs and the management. And so that is something that is an issue in some places, probably more in the Northeast than here, but could also be happening. What else?
If it doesn't give you a high, why is it getting diverted?
Okay, so it doesn't give you a high when you are in a methadone treatment program because your dosage is calibrated by your physician and nurse team who looks at what is the dosage that you need. And like any other medication, depending on your disorder and the length of time and the other factors in your case, would determine whether you're on 30 milligrams or 60 or 90 or whatever. So when someone gives it out in a pill form, as a private physician, those pills can be put together and you can exceed what would be called a therapeutic dose. And just like any medication, including aspirin, you can, get adverse effects. And in one case, adverse effects, and thank you for bringing up, that's an important distinction, could be that in taken in excessive doses, you can get some high effect. So my point is that anyone who is in a formal methadone treatment program that is working that program effectively, they would not have any high effect. Now, does that mean that if they go and take other drugs on top of that methadone, like they don't quit, let's say, because few clients just are using one thing. So if they're using other drugs, could they not appear when they come to meet with you? Could they not appear to be high? Absolutely, they could be, because they may not only be taking methadone. But the reason that I say this is that if you are working with such a client and you see behavior that is ringing your bells as, something, I may not know what it is, but I know this, something isn't right. This person is acting and behaving in a way that is not conducive to just a stable person, then that is something that would need to be talked about in team treatment or in your other team meetings to look at what else might be going on. So thank you for raising that. And those are very important distinctions. So often in addiction, drug testing is seen as a solution to the problem, or even worse, seen as good as or comparable or synonymous with treatment. And that's a very dangerous distinction to make. And let's look at why. This is a spectrum of substance use disorders, and this shows, you've probably seen things like this. So we show in the first phase experimentation and use. Obviously, that to pass into dependency, you first have to try and see, what happens with the alcohol or other drugs. And lots of people fall in this category. There may be people likely in this room that are in this category of alcohol or other drugs. You might have a drink at a party, you have a glass of wine with dinner, or you could also call some of this recreational use. There are members of the workforce in probably every industry in America that use drugs recreationally, that come to work every day, that parent their kids just fine, that are by all other standard measures successful. So the use alone does not speak to your efficacy as a parent or your responsibility to your family or your ability to maintain a job or anything like that. So however, obviously if you've got genetic predisposition, you're not probably going to stay in this little experimentation phase, recreational phase very long. So what happens is you begin moving into the abuse phase of the spectrum, and usually that begins in a couple of ways, in that you begin breaking promises that you've made to yourself. So you say, I smoke pot, big whoop, but I'm not going to smoke before I go to work. I don't smoke and drive around my car. I keep it together. So then all of a sudden, my boss is out of town this week. I'm gonna, smoke a little bit before I go to work or before I go to school. So you begin, I know I only do it on the weekends, but I'm gonna make an exception because I have a real stressful day. You begin breaking your promises. And so your trajectory begins moving towards the dependency phase. And when you get into the dependency phase, your ability to control your use is gone. So it doesn't matter. And by the way, information doesn't change that. I mean, if you think about that, you go to a program and maybe get drug ed. Okay, just knowing, this drug has chemicals. This is harmful. Okay, you might as well talk to the wall. That has no impact on somebody who has a dependency, who's got lots of other issues going on, and we'll talk more about what could be helpful. But here's the interesting thing. So we drug test sometimes to determine whether we're going to give kids back, or whether we're going to take kids out of the home, or whether we're going to have a TPR, a termination of parental rights, or not. And so really, what does drug testing do? It really only tells you one thing: that person on that day had that drug in their system. It doesn't tell you that they might have had 4 months of good recovery under their belt and abstinence, and that they could have been doing fantastic parenting, and they could have gotten a stable place to live and everything you would ever want for that family to become stable. And something may have happened. That disease reared its ugly head, as it will do, and they relapsed. And a relapse doesn't mean that they are going back to the beginning and starting over. It may be a slip, not a fall. It may be something that, with the proper response, or can get right back on track, and this was a mere hiccup in the big picture. Or it could mean that they have never addressed the addiction problem. You don't know, right? It's just if you just do the one test. So one of the things that we recommend, I hate going through this little light thing here, and I've been recommending this in Nebraska for a pesky year. Hopefully someone will take me up on it, but I'm going to pass this around. This is a form. This is a document, by the way. We're going to give you lots of access to lots of resources. If you Google on the first slide, the National Center, if you Google the acronym NCSACW, so it's National Center NCSA for Substance Abuse, CW, Child Welfare, just a little acronym on your very first slide. You will go into a portal that has just countless amounts of documents and guidance assistance and technical assistance and sample templates and sample policies, and everything you could ever want or need is probably on that website. One such, and all these are downloadable and free, and they can also be ordered for free. And we'll have some things sent to a central place here so that y'all can have access to them as well. But this is called SAFER, Screening and Assessment for Family Engagement, Retention, and Recovery. And in here is just one of many tools, a very simple form, that basically is something that we believe every judge should have, and it should be completed, and probably every child welfare staff person, and it should be completed by addiction treatment providers, and it has 4 criteria. It says, how many sessions, treatment sessions, was the client supposed to go to, and how many did they go to? How many urine drug tests was a client supposed to have, and how many did they have, and what were the results? How many AA, NA meetings was the client supposed to attend, and how many did they go to? And how many meetings with the recovery support coach or recovery specialist, which sadly I don't think you have in this state, but is a huge boost to treatment outcomes. How many of those sessions were you supposed to have, and how many did you have? So now what happens is a judge trying to make a very difficult decision about whether or not to remove kids or TPR or whatever, now has a pattern of behavior over time that they can look at, to not a single test or a single point in time, or not even, more difficult. Sometimes they'll say, to a treatment provider, well, how's Sally doing? How's the family doing? First of all, Sally might say, the judge says, well, are they in treatment? Oh yeah, Sally's in treatment. Yeah, she's still there and she's doing good. Really? How do you know? What are your behavioral indicators? What's your credentials to say she's doing good? How much experience do you have? You're right out of college, and maybe this is your first drug client you've ever seen, or your first set of clients. Not that somebody out of college wouldn't know what to do, but I'm just saying it's one factor. All right, it's one opinion that may not be well informed by a lot of experience. So this is a very concrete example of, at least it's not the perfect tool, but it is one tool that gives more significant information. So let's say we don't have such a tool too, and we say, yeah, the client is still in treatment. What does that mean? Well, I know one thing that happens in this state, that happens I think more than in other states, is there seems to be a high use of low intensity outpatient treatment. And just so you know, that is typically not at all the case in other states, and is not typically appropriate for someone whose addiction is so advanced that they are maltreating their children, okay? Popping in for an hour a week does almost nothing for most families in the child welfare system. Are there some occasional families that might be appropriate for an hour a week intensity? Sure, probably there are. And so part of our challenge is really teasing out who those are and who those aren't. Does that mean, yes?
One thing I deal with is I'll have a client who will, for whatever reason, there's a significant delay in getting them to treatment. 6 months, 9 months, on either side of this. And they can say, well, I've passed every single drug test, I'm working, I'm going to all my visits, I'm doing everything I can. So obviously I don't need the treatment. And so then as their tests turn out, going in and asking for an evaluation.
Right, okay. Good question, good. And actually you had a couple of really good points in that question. Yes, okay, so the question is, you have a client who comes in and the part that's the most alarming was the pesky 6-month delay to get into treatment or longer. And we've heard this all over Nebraska, by the way, in spite of some leaders telling us, oh, that doesn't happen. And I know that now that that's not true. And we have some data that will show that concretely. But, so that's one huge problem we'll talk about in a minute. And so the other issue is that while she was not able to get into treatment, she was working and passing her drug tests and doing well. And so did she really need treatment, or does she really need another evaluation, and what would be needed? And so, it's really hard to say, not seeing that client personally and looking into the details there. But it could be possible that someone who is able to maintain a job and maintain a safe home and have a period of time as much as 6 months and not be in treatment, and especially if she's got AA and NA and other kinds of support in place, it may be that she is okay. It's hard to say really without seeing her. I would suggest that those cases are few and far between, maybe not the norm. Okay, and may have represented a case where an outpatient kind of scenario could have worked for her. Hard to say not seeing that client. But here is a piece on that front end of your question that we need to talk about, and that is the concept of time to treatment. So one of the factors in addiction as a disease is that there is a need for urgency. So you've got a mom or a dad or a family, and you've got, child welfare knocking on their door saying, we have had a report of maltreatment, we're here to investigate your family, so maybe we're even going to end up taking the kids. And you have more than you will ever have again in that woman's life the highest degree of motivation for her to do whatever it is going to take, or those parents, for the most part, there are always exceptions, to get into treatment and to try to make the kind of changes that need to be made. That I don't even call it a window of opportunity, it is a peephole of opportunity. And that opportunity wanes every single hour, every single day that goes on. And now finally, there's new research out as recently, actually the article that I have is not even out yet, it's pre-release, peer-reviewed journal article that for the first time speaks to not only the time to treatment being a critical factor, how long it takes you to get into treatment determines whether or not you'll ever go, but whether or how long you stay in treatment, how long you stay engaged in treatment now appears to be related to the variable of how long it took you to get into treatment. And only one research article, and it may be around an alcohol population, it's a very complex article that I don't pretend to understand completely, but we'll be reviewing it and also speaking with the researchers. But we've suspected this actually for many years, and I have a little data I'll show you later that will bear that out. So what it says is the urgency and the need, and any of us who have worked in addiction, we know how motivated those moms are at the beginning. And then when their kids are taken in particular and they're gone, there's a point at which it seems so overwhelming to them and so, that it's so hopeless that all they do is want to go out and keep using. And so you've really missed that window. So what happens is a lot of addiction providers, and I'm sorry, I'm going to ruffle some feathers here, say, we're backlogged. We're backlogged, and the best we can do is 6 weeks, and we hear all over the state 6 months, okay, in some cases. So interestingly enough, there is tons of research, you can look for it yourself, through the NIATEX called National Improvement for Treatment Initiative, or something like that, NIATX, you can Google it and go to their website, that they have looked at what can treatment providers do, or assessment providers, to be able to shorten that time to treatment. So they went with something called open access, which is we don't set appointments. Because what happens when you set appointments? We already all know this, it's so obvious. You set an appointment, it's 6 weeks out, God forbid 6 months out, and what happens? Client doesn't show. But what do you have? You have the counselor sitting there ready for the client that doesn't show. Okay, so we've, and I'm not saying they put their feet up on their desk, paint their nails, eat bonbons, and but what they go on to do other things, paperwork and all these other things that they have to do. But the bottom line is that client didn't get served, and there was an hour of time or 2 hours, a few years in a gain, or 3 hours, that was set aside that never got used. So what happens is we did experiments all over this country. I believe almost every state now has proven this, where we said, let's dispense with appointments. Let's see what happens. And of course, you have a lot of hand wringers out there. Oh, we can't do that. What's going to happen? We're going to be flooded. We're going to have people out our back doors. We're not going to be able to manage. And guess what happened? Nothing like that. Sure, every now and then there'll be like around lunchtime or there's predictable patterns that'll develop, or you might have a few clients. They were absolutely not overwhelmed. In fact, the best example was in West Virginia. They increased for $0 their intakes by 200%. $0. So don't take my word for it. Go look. Go look on the website. Spend some time looking at the research. There is no reason why open access is not used in most places in this country. There's no good reason, okay? Now, I realize there are some exceptions, okay, and that may be in some places where you may have to travel long distances, 2 hours to go, maybe there's not an assessment provider, and I say, and they told us in some of these places in Nebraska, oh, well, we get a shot at a person like every 2 weeks. Okay, so if that client can't come at that one time, or has other appointments, which they're typically going to too, or is sick or something, then that means it's a month before they get seen. So I come back to, is that reasonable? I think we can do better, frankly. I don't know if it's telemedicine. I don't know if we do it on an internet. I don't know whether we come up with another model, but that's on us. That's on us to do. That's our problem as a system. That should not be the client's burden. They have enough burdens. They're wearing enough monkeys on their back. We don't need to put our stuff on them and say, well, that's how we do it, or that's what our schedule is. We can do better. We absolutely can do better. So we now know in most situations that if you can get that client in, and the states that are using Niatex are primarily getting them in within 72 hours into treatment, not into assessment. Oh, here's my personal favorite, and I will pick on Nebraska a little bit here. The fun-filled pre-treatment assessment. For clients who have already said, I want to go to treatment. I have a drug problem. Please help me. And so how do we help them? And I don't believe this is true. I believe that it's bad information out there. I believe that anyone who has good common sense, I'm probably not being invited back to Nebraska now, but who also, you don't have to have an appreciation for addiction. You don't even have to know how to spell addiction, but common sense would tell you if somebody says, woohoo, I have a problem, I'm desperate, please help me. And we put another hoop out there for another thing for them to jump through and say, we need a pre-treatment assessment. So, I understand if they don't cop to that, okay, maybe, I don't know. But if we do that pre-treatment assessment or screening or whatever you want to call it, it should be immediately backed up by the full McCoy, if they show up. They shouldn't have to have yet another hoop to jump through. Your opportunity to get them in decreases. Now, there might be some reasons financially that there are folks that might think that's a good thing, but that's not the right thing for the client. That's not the right thing for the family, and I don't believe people really do it with those intentions. But the net effect is the same. So I think what happens is there is no requirement, and someone can correct me, that if a client admits to and says, I have a drug problem and I need help and I want to go, I don't believe that they would be required to do a pre-treatment assessment. But I do think that there's some misinformation, out there, and so people are holding up that. And one statistic I've asked for, and if I have to look it up myself, I will, because I know we have the data, I think now, and that is I want to look at the number of pre-treatment assessments that we don't ever see again. See how much our drop-off is. I'm going to show you some kind of startling drop-off data that we have now. Yes?
If you use pre-treatment assessment to also loosely mean substance abuse assessment, I do think to access the higher level care, the short-term res, the long-term dual, I've not seen a treatment provider that will accept one without one.
So, because I've been told that a pre-treatment assessment is essentially a screen. And I view a full-fledged assessment as what would determine level of care.
A pre-treatment assessment, again, if you're talking about a mental, loosely, it can be a substance abuse assessment and a mental health assessment. It is not simply a screening tool. It is really supposed to be an in-depth clinical guided interview. May include the SASE, MASS, DAS. It really is more than that.
So what would you learn from that if a client says, I have an addiction problem and I need to go to treatment? And we already know to get into treatment, they already have to get a full-blown assessment, right?
Well, this assessment, pre-treatment assessment and a substance abuse assessment, depending on who you talk to, can be the same document, can be two different documents, similar documents.
So it's not a standard. So pre-treatment PTA is not a standard tool that everybody has the same one in use.
Substance abuse assessment.
Oh, good. Okay. Could you clarify? Thank you.
Okay. Mental health assessment before you start mental health treatment is the PTA. You don't need to do a PTA before substance abuse. You need to do, in Medicaid, you need to do a substance abuse evaluation. In MPHS, you don't do PTAs. You just go in for your substance abuse evaluation.
Thank you. And that's basically, but really even what you're saying, we hear that everywhere we go, that there is still a sense that if you have even if you have a substance abuse problem and you say, I need help, that you are required to do a PTA, and you're saying that isn't the case.
Well, a PTA
right?
and substance abuse assessment, they sometimes look very similar. It's just really the focus.
Okay.
Mental health or substance abuse. What I see in child welfare is the PTA assessment is often seen as the first way of doing some type of family assessment to determine what the family's needs may be. Substance abuse, mental health, depression, the whole host of it. It is screening out assessment.
Right. So because in the standard terminology of, let's say, screening, which is the SASE and these other kinds of things, and I'm hearing your PTA is really not screening per se. In the traditional sense, you'd get the screening first, and that's up or down, substance use, yes or no, and then you would go for a full-fledged assessment that would look at all those domains you've already discussed and whether you have a co-occurring mental health disorder, so that really, you know, it could be viewed almost as duplicative, that if you're looking at all those domains and all those other issues at a pre-treatment assessment, it seems in some cases that would be somewhat redundant on what a comprehensive assessment would be.
There are lots of redundant.
Yeah. So the point of all this is, you know, let's make sure everybody is on the same page of information and that we don't create barriers when we don't need to and create delays to treatment when we don't need to if we've got somebody who is, you know, crying out for help and ready to go for help. So, so here's just an example of a slide for relapse that we show that drug addiction has a 40 to 60% relapse factor. So let's call it, you know, halfway point, 50%. So half the 50% of your clients are going to relapse, and that's to be expected. And what you do with that relapse and what therapeutic interventions are conducted at that point is really the makes the difference in how successful that client can be going forward. And so this is really not atypical to diabetes, hypertension, and asthma. In fact, hypertension and asthma have higher rates of relapse. Yeah.
What is the definition of relapse in this context?
And relapse in this context is a use of drugs after a period of abstinence.
Any use at all?
Any use at all, yeah. Now, really, if you look at what percentage of that would be a full-blown return to pre-abstinence conditions, that might be more like, so both of those are actually probably included in here, now that I'm thinking about it. But I know that this includes even just a temporary as well as longer return to drug use from a period of prolonged abstinence. So, you know, very, very much expected that you would expect somebody is, and you want that to happen in treatment. You want them to, you know, and that happens a lot. Somebody gets some recovery under their belt, they feel like they're getting stable, and they say, wow, now I can return to that spectrum I showed you where you have that sort of experimental use or recreational use, and they say, I can handle it now. Now I've got the tools. I got the tools in treatment and my life is on track, and I miss that drug, so now I can manage it. And of course they can't. But you want them to find that out while they're in treatment, while they have a support system, while they have a way to be, you know, stepped up if need be, or to have different plans put in place for their recovery or more support added. And so that it's not a throw them out, kick them out, you know, scenario. They are manifesting their disease, and that will happen 40 to 60% of the time for the clients that come into our treatment. So you can expect it. Yes.
Is the percentage different depending on the type of drug?
Yeah, depending on the type of drug. Some drugs are more compelling than others. It depends on, it's on a lot of factors. How much time that person has used that substance. So folks that have a 15, 20-year drug history are going to have more likelihood of relapsing than somebody who might be newer into that. In some cases, it has to do a lot with the support that they have, has to do with their environment. It has to do with a lot of factors. Yes. Oh, yeah.
The main thing is, I think a lot of it is the
Support.
support. Not looking at what the families are doing.
Right.
They're going back to the parents.
That's right.
Stuff like that.
Right.
Pretty much guaranteed that.
Right. Well, and you know what else it has to do with? And I'm going to advance a minute because I'm going to show you, and I think this really says it all. I'm going to advance just a minute and show you some, to me, it's just so obvious when you see this. This is going to be a typical case, typical child welfare case. This is from New Jersey, though, not from Nebraska. And I know that there'll be some differences, particularly in this one was using opiates. But this really becomes a very obvious thing to me. Here it is. Okay. So here's a typical case of Nebraska. Literally pulled cases in Nebraska to look at in New Jersey to look at who we see. So this is a single head of household mom. There's a lot of those where the child welfare primary client is a single head of household mom. In this case, 28 years of age, 7 months pregnant, getting no prenatal care. and has 3 kids, 2, 4, and 8. And I want to stop right there and just let kind of let that resonate for a minute. You're 7 months pregnant, okay, for women, and of course the men can appreciate this too, how cranky we might be if you're around us. And you got a 2-year-old, 4-year-old, and 8-year-old wreaking havoc in your home. And you get a sense of some of the chaos, okay, that's there. And these are families that aren't living in, beautiful homes with lots of resources, and, they can have a little time out, and they can, go to their media room and take a break, These are folks that have no stable employment, typically no family support, no resources, no way to get any kind of a break or some help. So even right there, if you just picture what that would be like, and then throw on top of that a 12-year drug history. In this case, heroin, cocaine, alcohol, and marijuana. She was an equal opportunity drug user there. Co-occurring mental health problems, which is very common with addiction, primarily anxiety and depression, but certainly other things as well. Criminal justice history, in this case, panhandling, domestic violence, she was a victim. Education history, 10th grade education, no GED. And employment history, she had no stable employment, and she was having some sanctions for not working. Had 2 prior involvements, no surprise, with the child welfare system. In this case, it was because addiction was not treated in the way it should have been. It was missed the first time, and I think the second time she got some low-level, drug ed something. It wasn't appropriate. And so she's back. And so type of family support, she had 2 different fathers, one's in jail, not getting any child support, so no help in that department. Living in public housing, which she may now lose because she had a drug charge. And she has 1 child with sickle cell anemia, and they couldn't identify any strengths. I think everybody has strengths. The fact that she can get up in the morning with all this going on is, to me, that's good. That's a strength. So at any rate, and this is not atypical to the kinds of families that you have, there may be some differences, less kids, or maybe, I think you guys have 1.7 kids or something, they have 2.2 in New Jersey. But at any rate, and there may be a different drug profile. But you take somebody like this, and you really just think about what that life must be like for that person. And may have even been a child that was in the child welfare system when they, themselves, and now they're a parent with the kids in the child welfare system. And you say to somebody like that, who's at their absolute bottom point, and now their kids are fixing to get taken from them or may already have been taken, and you say, we're here to help you, and just hold on, and 6 weeks from now, we're going to get you in for an assessment. It's going to be a pre-treatment assessment, and then a few weeks after that, 6 to 8 weeks, we'll get you, and I'm being a little sarcastic, I'm sorry, but, there's, and hold on still, because it gets better, we're going to get you into treatment. And what is treatment? So in some places, I'm sure it is absolutely fantastic and is everything you could ever want. And that's great. And hopefully we have a lot of that in Nebraska. I know we do. And I know some of the providers in this room, and they will get the absolute best treatment you could ever expect. But I also know, as in every state in the country, we also have some woefully inadequate, primarily probably because of funding, but it also there's issues around no cost, low cost interventions. It doesn't cost anything to be kind and compassionate and understanding, and to be flexible, and to try to really understand what the issues are with a family, and to make sure you do everything, you make every reasonable effort to try to help that person. And I know that doesn't always happen in any state. So you take somebody with this, and you look at what do they need. Okay, and we're going to have a video in a few minutes that will give some suggestions. But she doesn't have a GED. Okay, so if she goes to a treatment program in Nebraska, will that program have GED classes? Will it, in handing her a phone number for GEDs, probably not, especially if she doesn't have transportation, especially if she's overwhelmed. That referral to GED, you could do studies yourself to see how many convert to actual GEDs, and it's not as many as if you have GED accessible to her in treatment. She needs, never held a job before, doesn't have any stable employment, so if she pops in for a few hours a week or hour a week of outpatient, and nobody is helping her develop job skills, you may have her in recovery, maybe, if you're lucky, for, especially if it's a real short-term program. When she gets out, but what's going to happen to her when she's out? You know, and she's a sober person in recovery, recognizing she has still no job skills and no way to get a job and support herself. And so what is likely to happen to her? She's going to, you know, trade her body for drugs, exchange sex for drugs, sex for food, go back to an old boyfriend, lots of things that will undermine her addiction. If she's still living in the same drug-infested environment, or God forbid with the same partner who helped her get addicted, just because she has, you know, a few drug sessions under her belt, is that reasonable to expect that she's going to be able to get back on track and be the kind of healthy parent that we would want her to be? Is it fair to even think that? Is it, you know, just common sense? I mean, really? We really think that that's going to happen? I know that's what we want, but these are very, very complex cases by the time they come to child maltreatment as a factor. Yes.
On the ASPA timeline, and you all know.
Thank you. Yes. On the ASPA timeline, and I jumped ahead. I have some ASPA slides we'll go back to. And you know, some states don't even train their treatment providers in ASPA, and yet they're serving these families. And so how that plays out is the client's a no-show. And you know, I mean, I was an outpatient counselor for many years too, and you'd say, oh, sometimes you're like secretly glad that they didn't show up. Now I can get to all that paperwork I have, and now I'm not going to lose my job. I can do all these other things I have to do. And nobody's saying, yeah, you know what, the fact that she didn't show today, her ASPA time clock, the number of months that she has to get stability and safety going, improve that so that she can get her kids returned if they're in out-of-home care, that clock ticks very fast. And if we burned up 6 months of that clock even trying to get her through all the hoops to get into treatment, and I know it doesn't take 6 months for everybody, but it's not 72 hours, and it's not even 14 days in most cases, and we have data now to show that. If somebody has something different, please show us, because we have some case data that we'll be reporting in a few minutes. So, you know, at any rate, really, so we are, you know, potentially as a system further traumatizing these families by putting unrealistic burdens and not giving them the dosage that they need. It's like we're trying to cure cancer with an aspirin. You know, we're just not giving them the full spectrum of what would meet the reasonableness test. Now, just one quick example. And people say, we don't have any money. We don't have any money. We're broke. Absolutely, I get that. And there's not a state I'm in that doesn't have that. And I know y'all have it pretty bad. However, really, that's not true. There's a lot of money in the system right now. And there is a lot of waste in the system right now. And there are, as in any place, there are examples of things that we're doing that when you step back and look at it with cold facts are really hard to defend. For example, in Nebraska, you have I think it's either 1.7 or 1.9 kids per child welfare family on average. When you go to out-of-home care, it's about 900 roughly per kid per month. So your average family is costing you $1,800 per month for every month those kids are in out-of-home care. That buys a heck of a lot of good treatment. And there are treatment models that we're going to talk about in a little bit that you can provide for far less than that, where the kids can stay with their moms in supervised settings where you'd never have to take the kids, and where the mom is in a nurturing, caring environment 24/7, and it's not residential treatment. But it feels like residential, looks like it is the dosage that you get in residential treatment. So, and states all over this country are doing these models with less resources than you have in small towns across America. And so it can be done, and I see them, I'm in them. I'm not telling you some fantasy story here, I'm telling you reality. And I'm very happy to say that we had a meeting yesterday in the afternoon, and there's a couple of folks that are looking at developing some of these models. So here's another way we waste money. And I honestly do not know. I know the first thing I just told you is 100% true. This next thing, I don't know if this is happening. Somebody here might know. Take alcoholism. By the way, alcohol is the number one, that alcohol misuse and abuse causes far more damage on every measure, from drunk driving, car accidents, deaths, fatalities, child welfare problems, far more than drugs, all the drugs added together. is less than alcohol. That's another thing about some of the drug testing. You're like, really? You're gonna spend hundreds of dollars on hair tests and da-da-da-da-da? We don't even look at alcohol half the time. So anyway, it's like, what are you really trying to measure? But put that aside. We will take somebody and put them through detox over and over and over. Could spend $100,000 on one client on detox. It's very expensive high medical staffed model. And yet our Medicaid formulary may not pay for Vivitrol, a $700 drug, an injection once per month, that will take all that chaos and the brain circuitry and all of that, calm that down, have that client be able to have a successful shot at recovery. $700 a month. I don't know how long that client, depends on the circumstances, but certainly for that early stage of recovery, who's a smart shopper? Even if we just look at the money, even forget that it's the right thing to do, why would we deny a substance use client the same opportunity that we say we're behavioral health, right? That, okay, that's good. They're all co-occurring. Everything's great till you get down to the pesky drug formulary sometimes. And then the substance use folks don't have the same opportunities that folks with mental health have. And that may not be happening here. It happens in most states. May not be happening here. So, there is money. There's money in every system. There's money that could be spent. Those counselors waiting on that appointment to show up, that's a no-show, because we gave them an appointment 6 weeks out. That, I'm sure they're doing something good, but they're not seeing a client. So, there is opportunities. We all can do better. And I'm, in the same situation, having been in these same jobs that you're in, at all levels, including running one of the largest drug treatment systems in the country. So, and I know this for fact because we also had similar challenges. So all I'm saying is we need to acknowledge where those weaknesses are and at least have a plan to improve. I know we don't make these kinds of, system changes overnight, but if you don't have a plan to change, if you don't know where you're going, where you're trying to go, any road will take you there. Let's see. All right, let's go back to so now we want to look at what are some of the other challenges that we're having? I hope I'm going the right direction. And the good news is there's a lot of things that we can do to improve the situation. Let's first quick look at some of the timelines that we have to deal with. And we won't be able to go through, oh, you know what? I had my clicker upside down, so I was advancing instead of going back. So is there any quick way to go back? I'm very technology challenged. So I'll talk about something else. So if you can just get me back to probably it's easier to go to the beginning and then I'll go through the other few slides that I already covered. So one of the things that we have as a tool is recovery support specialists. And recovery support specialists are persons in recovery, preferably with a few years recovery under their belt. And in your system, and what other states do is they have persons that have been through child welfare and had addiction problems, who literally at the point of removal or at that crisis point in a family, often they'll go with the PIs, the investigators, or they'll go with, or shortly thereafter, and they're going to say to that family or that mom, I know exactly what you are going through right now. You are, they've taken your kids. That is the, worst possible thing you could think about happening. Thank you. There's a lot of blame, a lot of shame, a lot of, oh, you're doing that for me. You're too, I don't deserve you. Thank you, Darren. And so you're feeling at an all-time low, and you're, all you want to do is go out and use. And I know there's a lot of complicated things being thrown at you. And think about our bureaucracies and things that we do and the acronyms. And think of that brain that's at 14, years of drug use that, is just not even able to, not only are they in a crisis, and maybe it's because I'm in my 50s, I can't remember what I did 2 weeks ago, what I had for lunch 4 days ago. And then, and I don't have these challenges. imagine having somebody there, and a lot of it's verbal, and even some things that are written down are, acronyms and bureaucratic mumbo jumbo, and they may have literacy challenges. And so we throw all this stuff at them, and it's overwhelming, and you almost just say, I can't do this. But you have a recovery support specialist there saying, you can do this, and I am going to be right there with you, and I'm going to take your hand, and we're going to walk through this together. And if I have to drive you to your first session, that's what we're going to do. If I have to drive you, to get that birth certificate, I'm going to Bogota, Colombia at the end of June, and they asked me, my passport expired, so I had to get it. So they asked me for my original birth certificate. I was like, I'm in my 50s, like my original, really, where am I going to get my original birth certificate? So I didn't even know where to look. Like, do you look up under B, birth certificate in the phone book? Like, where do you go? And it took me hours to sort through all the stuff I had to have. And I think, what would you do if you had, because sometimes you have to have like documents, to get into especially residential treatment, or to prove you're not an immigrant, or whatever you make people do here. And so, to have somebody who says, I'm gonna go with you. I'm gonna hold your hand. We're gonna do this together. We can do this, And so, and to literally do warm handoffs, to literally hand that client off to the next step and the next step and the next step. What a difference that makes than basically, handing them slips of paper or verbal commands, or I don't know what else is done, but it makes a big difference. So. Recovery support specialists, when added to treatment, boost treatment success significantly, and also increase savings to that system. And we'll show you some data in a little bit that a recovery support model attached to a family dependency drug court saved, I think it was $132 or $131 million in 1 year in out-of-home, in costs that were saved in out-of-home care. The problem is, and I don't know that you have it here as bad as other states, that sometimes if we do the right thing in one system, it saves money in someone else's system. And so that's always hard, to do. It's like, I'm so glad I'm going to spend all this money to do drug treatment the right way, and glad that you're going to save a whole bunch of money in child welfare. But, but how does that help me? And it increases my burden. And so I know there are some bureaucratic issues, but that's also why we have to work together to do this. So in many states, they funded recovery support using existing resources, and we're fixing to do that in New Jersey. They had some kind of workers that did something that, frankly, if you really looked at it, didn't add a lot of value. They were busy, they ran around. I think it was even some kind of a pre-treatment assessment, kind of, not quite, but something like that. And we said, you know what, why don't we convert you to recovery support specialists? And let's test that and see whether spending the same amount of time in the same budget, but doing something a little more meaningful, more concrete, is going to make a difference in child welfare outcomes and length of reunifications and numbers of reunifications, like it has in other states. One issue we're having, though, is that we have to deal with existing staff. We have one staff that we have an open position, so we can hire someone in recovery. The other two are not in recovery in this pilot, and so it's not as great as having someone in recovery, but we're going to work with what we have, and then as openings occur in those positions, we'll try to replace with somebody in recovery. So I'm going to advance now to some recovery support, but these are just examples of some of the addiction medications that are available. They all do different things, and they're all designed to support and help maintain recovery, or to, in some cases, you have adverse effects if you're taking these drugs and then you try to go out and use your illicit substance. I'm going to speed through some of this because we've covered quite a bit of this. I do want to go back to one thing, and that is one of the things that trips us up in every state in the country is our underlying values and underlying values differences across the systems. And I say this, and when I first got indoctrinated in 2007 with the National Center, this was just drilled into us. And I remember sitting there going, yeah, right, we're going to hold hands and sing Kumbaya next, values. So I honestly, to admit, I just sort of did not accept that information until I got out there, in some of these states, and realized that we had great kinds of information we were presenting, we had great tools, we had all kinds of things that we were offering, and nobody was really taking us up on it, or it wasn't working initially. And we found out what was tripping us up from the beginning was underlying values differences. So even as simple as how you handle relapse, how you define success, how you define reasonableness. What is reasonable? What's a reasonable effort in treatment for somebody that has that profile that I showed you that was so complicated, as most of them are. And so really this gets to the need to spend time. And a lot of times we're so busy we don't even talk to each other. And sometimes we're in these states and people are meeting each other for the first time and they're working in the same town, working with the same families. And so, and I don't mean just communication, I mean meaningful communication. And let me give you an example. I told you I work in Miami, and you might be familiar with a very devastating recent death that occurred in Miami of a child. It was a sibling group that lived actually, they were actually in a new adoptive home. And of course the mom, as in almost every death, if you look back, substance abuse was a factor, often undertreated or not recognized. Almost 100%. You can look yourself at your own statistics. So in this case, the mom had an addiction problem, wasn't identified early enough. There were some other issues. She didn't get the kind of treatment she needed. She lost her kids, and they were adopted. Unfortunately, this death occurred in the adoptive home. But they looked at, there were so many signs, and you can pick up any newspaper in any state and you see, children that were wasting away to nothing, like did really nobody notice, it didn't get to that point overnight. There's always signs, always some signs, that someone sees. But what happens is even if we communicate in these little sound bites and little tiny, and so we might say, oh yeah, someone's in treatment, but we didn't really go look, well, what does that mean? Well, they've only shown up once in a month, or only for an hour, or they left early, or or they're not maybe getting the kinds of things they need. So really the kinds of collaboration and the kinds of discussions that the Miami report, I just got a copy of the findings, say it's not just about communication, and it's not just about monitoring so much. It's really deeper. It's the need for deeper level communication that's meaningful and that looks at the important factors and not the sort of on the fly kinds of stuff that we typically do. So how we define abstinence, I'm going to give you an example here and then we'll take a quick break. And I'll give you, when I worked I helped to start this program in rural Georgia, and it was, I might have told you this before, it was so rural that when I went as a consultant to be working with that group in Cuthbert, Georgia, and I was staying at a motel, not a hotel. I called ahead to see what the amenities were of this motel, and I meant high-speed internet. And they said you have wall-to-wall carpet and a telephone, in-room phone. So I was really, really pleased about that. But I'm just wanting you to appreciate just how rural this place was. And it was about 2 hours to any city center that had, even any kind of stores or infrastructure or anything. So we put in place 20 homes, prefab homes, and we created like a village for families that had child welfare and substance use problems. And we used Department of Agriculture money because we could, because it was rural. And we used Department of Community Affairs money because we could. It was available, still is usually. And we did some creative things and we built this amazing place. I'll show you pictures in a bit. So we worked with, and all the moms had to have child welfare involvement and addiction. And we did, that was criteria to get in. And so we had this mom, and I wish I were making this up. She had 5 kids, 5 different fathers, all different biracial combinations. In rural Georgia, just so you know, that doesn't make them real easy to adopt. I don't know how it is here, but a lot of stigma and a lot of racism and things in the rural South. And so so let's just say it was a very costly family also, if you think about TPR and you think about that, all the processes that go forward. So we got her into this program. She was a crack smoker, smoked all the time, crack. And she would drive her kids around in the car while she's smoking. And so really probably one of the more severe cases we'd ever seen. And so we put her in this program and she thrived. She had hope for the very first time in her life, that her life could be anything other than what it was. And she was getting help for her addiction, for getting some spirituality, getting some services that she needed for her children to help them get back on track with their developmental milestones. She was getting job skills and training, and she could see her life, and everything was great. And one day, after she put her kids to bed, she went out on the porch and she used drugs. And she came, I think it was crack, and she came in and told us the next day that she had done that. So the child welfare staff came in and said, that's it, this was her last chance. We told her this was it. If she relapsed even one more time, we were gonna pull the plug, on and on. It was a lot of work for some of us that didn't think that was the right thing to do, to sort of reframe that relapse for the child welfare staff. And also the courts were a little perturbed and say, look, look at where she's come. You know, look at what you had to start with. In 3 short months, she has had the longest period of abstinence she's ever had in her like 17-year crack history. You know, her kids are doing great. Her parenting she has a relationship with her children now that she didn't have before. You know, look at all the things that have happened in her life. And that she came, first of all, she made sure her kids were safe before she used. Even that, you know, harm reduction maybe, but even that was a step forward. And she came and told us. And so the good news is we were able to work with and through that, and she ended up being one of the most successful clients we had. I can't tell you what would have happened to have, you know, we would have had to split up a 5-person sibling group in rural South Georgia with different fathers and all the other issues that were there. And that would have been a real expensive, even if you just look at the funding. But it really made it clear to me then, wow, we all really do look at things differently from our perspectives. You know, we all probably have the same overall goal, healthy families. We can all salute that and smile and feel good. But it becomes nothing more than a slogan, really, if you don't think about, well, what is that? How do you translate that into real practice? What does that look like? So she was doing great and still is. And many of the clients that we've treated in these really comprehensive programs were the ones that you would have stepped over in the street. They were the ones that you had to yank out of the crack house. They were the most intractable examples. And so, you know, but having that comprehensive care and being able to have a good sense of defining success, and that sometimes means they take 3 steps forward and 2 steps back, and then another 3 steps forward, but at least they're moving in the right direction. But if we don't have these discussions, we don't make these and a lot of this is very individualized. It really depends on that person's circumstance. And so anyway, we'll go ahead and take a break. Let me just check in with you before I turn you loose on a break. Does this make sense? Is this helpful? Is this okay so far, the information? Okay. All right, so Vicki, what are we